Good evening, ladies and gentlemen. Welcome you all to this webinar session, ECG Basic and Beyond, organized by ECG Study Group. Last week, on the 21st February, it was International Mother Language Day. And on that occasion, we have declared a ECG quiz contest. We have given 10 ECG quizzes and more than 50 participants participated in the quiz contest. And today we'll discuss these 10 ECGs on the first part of the session, and the next part will declare the winners of this ECG quiz contest. The winners of the ECG contest will get a book, a textbook of Basic and Advanced Electrocardiography, which is written by Professor Boren Chakraborty sir, and we are happy to declare that Professor Boren Chakraborty sir is with us. As usual, we have got our course directors, Professor Atahar sir and Professor Abdul Wadud Chowdhury sir with us. We have got our international advisors, Dr. Rafiq Ahmed sir, Chowdhury H. Hassan, and our other panelists, Dr. Abdullah Jamil, Dr. Naruma, and Dr. Govindapal. At the beginning of the session, may I request Professor Atahar sir to say a few words about today's session.
No, Chowdhury, Abdul Wadud Chowdhury. Chowdhury.
He's not. Probably
No,
he's
I think আমি পরে কথা বলবো আপনি কথা বলেন স্যার গাড়িতে
Atahar sir, you can proceed. He is still on the way. Atahar sir.
Sir, unmute yourself, sir.
Sir, Atahar sir, please unmute yourself.
Good evening, dear participants, honorable panelists. Nearly after 1 year, on the occasion of International Mother Language Day, the ECG Study Group has arranged a ECG quiz contest just to see how our participants react and what is our actually how much our benefit that is we have given to our participants. So this is just to see actually our dear participants interest about the ECG contest. Today I am very much happy to welcome our honorable panelist, particularly Professor Abdullah Shafi Mozumdar sir. He will join soon. We have also Professor Abdul Wadud Chowdhury, Dr. Abdullah Jamil, and also we are very much happy to declare that is Professor Boren Chakraborty with us. And finally, we have got the international faculties panelist, Professor Dr. Rafiq Ahmed sir, Chowdhury Hassan, and Professor Urun Maski from the Nepal. And finally, I like to thanks Dr. Ashif Jaman Tushar for helping us to prepare the ECG quiz contest. I am also grateful to our Rafiq Ahmed sir, who has actually edited all the ECGs, given a lot of time to prepare these ECG quizzes. So dear participant, we'll just proceed to our next session, that is the ECG quiz contest session. About the design of the quiz contest session, Dr. Firoz will tell something about the how will the today's program will run. Dr. Firoz.
Thank you, sir. In the first part of the session, as I have already mentioned, we'll discuss the 10 ECGs. We'll ask the participants, one of the participants, to take part in the discussion, how they interpreted it, and we'll also take opinion from one of our panelists regarding this ECG, and also opinion from our international advisors, Dr. Rafiq Ahmed sir, Chowdhury H. Hassan sir, Professor Urun Maski. All of them will make comments on this ECG. So may I request Rivu to bring some participants in the panelist column. Yes, sir.
I'm going to share the slide.
Yeah. Okay, sir. I'm taking some of the participants in the panelist.
Okay, and then I'm going to share the slide so we can go from there, right?
Okay. Okay, sir.
Yeah.
So, shall we show the first ECG?
Yes, sir. You can go for the first.
Okay.
না না আমি শুনতে পাচ্ছি না তো না 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 না
Firoz, you decide who is going to discuss.
না না Atahar
Sir, we have make a plan, sir. That is, one of our participant will first discuss the ECG, then our one of the panelists, and finally you, Hafiz sir, Urun Maski will be the final discussion. So we'll call the one of our participants from our participants. Sir.
I think one of our
Sir.
participants, yes.
Yes, 3 participants are in the panelist now, sir. Dr. Buddhadev Ganguly, Atanu Das,
Okay.
and Dr. Mukul Chandra-Paul.
Okay. Now we can start discussion about the ECG. May I request Dr. Buddhadev Ganguly to can you open your camera? Can you show yourself, Dr. Buddhadev?
Video on.
Can you make your video on? Dr. Buddhadev, are you with us? No. Dr. Mukul Chandra? Dr. Atanu?
So
we can ask one of our guys from Nepal.
No,
Manoj
no.
Koirala? Manoj
Okay.
Koirala?
Manish Koirala, are you with us? Manish, no. Dr. Mukul Chandra, Dr. Buddhadev Ganguly.
Sir, Dr. Manoj Koirala, I have brought him in the panelist.
So whether they're
He's
muted.
here.
Dr. Manoj, can you
Or you can bring Arjun
your
also.
camera on?
Arjun Budathaki.
Dr. Manoj?
Manoj? Manoj, you are not here? Arjun?
Okay, we got Dr. Mukul Chandrapal. Please unmute yourself. Dr. Mukul.
Arjun?
Okay, we got Dr. Mukul Chandrapal.
Sir.
Please unmute yourself. Okay, Dr. Mukul Chandrapal.
Sir.
Okay. You have seen this ECG. ECG number 1. What is your opinion? What was your interpretation? Can you read the ECG for us? And you know the format which you described.
What
Yes.
is your opinion? What was your opinion? Can you read the ECG for us?
So this is the one. So one, this is a normal ECG.
Yeah.
Say, sir, another thing.
Yes, we can hear you. Please go on.
Acha, Firoz.
Chat.
Actually, Mukul Chandra has given the final opinion that this is the normal ECG, and this is our message from the study group to our participant. Actually, many of the times, Professor Wadud Chowdhury and finally Dr. Rafiq Ahmed sir actually what wants to teach our participant that we have to comment sequentially like this. That is Mukul Chandra Pal. You can see that is you have to first comment the rate of the ECG. As you see that is the rate.
Atahar bhai, can both of the two guys can comment now? Arjun
Yes.
and Manoj, then we can discuss.
Okay.
Rivu, can you make
Dr. Manoj,
Arjun?
you are Dr. Manoj, unmute yourself and you can also comment.
He's saying he's trying to unmute, but it's not coming.
Try to maintain the format we have prescribed. That means the rate, sinus rhythm, P wave, PR response, SPT, the sequence we have prescribed. Dr.
Manoj?
Manoj, please.
He's saying he cannot talk. Manoj and Arjun is saying they are trying to unmute, but they are not able to talk.
Dr. Manoj is unmuted.
Yeah.
He
So
can talk.
Manoj, can you talk now? Manoj? Arjun?
Here you are, Amin.
Hello.
Assalamualaikum, sir.
Yeah, Arjun, I can hear you.
Hello.
Yeah, Arjun, can now talk
Yes, sir.
sequentially.
Good evening. Good evening,
No.
professors. Yeah. So this is a 12-lead ECG of 27 years old female with normal calibration and normal speed. That's 25 and 10 millivolts. The rate is about 75 beats per minute. The rhythm is sinus, and the P wave morphology is normal. QRS axis is normal as well. But there is a slight, there is a poor R wave progression. So because the equiphasic lead is at V5, otherwise the ECG is normal.
Thank you, Dr. Now, may I request Professor M. Atahar sir to make some comments on this.
Thank you, Manoj, for your excellent introduction. But I think we have to be actually, what is our objective of learning is that we have to go sequentially as per principle. That is the rate is about 66. We have told 75. That is 66 per minute. Rhythm is sinus as evidenced by the positive P wave before the QRS complex, particularly in the lead 2. TR interval is 160 millisecond. That is from the beginning of the P to the beginning of the QRS complex. Then QRS, axis of the QRS is normal as evidenced by the positive QRS in lead 1 and AVF. And the duration of the QRS complex is about 80 millisecond. Then the ST segment is normal. And QT interval from this ECG within the normal range as it is less than the 50% of the RR interval. And there is no chamber hypertrophy. So this is the criteria of the normal ECG, and this should be imprinted in our memory. That is that this will be the basic for diagnosing the other ECG. This is the normal ECG. We have to keep in mind what is called the normal ECG. And Robik sir always likes to see this ECG first. And I think Robik sir will comment that is about this ECG, about our participants' comments. Robik sir.
Thank you. So this is actually the ECG that is the commonest ECG in clinical practice. 90% of ECG that we will see in clinical practice will be this one. And if we can identify, we have identified 90%. So at first impression, this is normal ECG. But then we have to justify why it is normal ECG. And everybody said sinus rhythm. Sure, there is a P wave before QRS complex. So it's an atrial rhythm. And the P is upright in lead 2-3 AVF. And that makes it that is coming from the top part of the atrium. One of the issues that you have to remember that you also have to look at lead 1. Why? If a rhythm is coming from left atrial appendage, it will be upright in 2-3 AVF, but it will be negative in lead 1. So that's why it's important. You look at 2-3 AVF and also quickly look at lead 1. So it's sinus rhythm. And then we look at rate. I never like to look at approximate rate. If you can you see my arrow?
Yes, sir, we can see it.
Okay, let me get the pointer. If I measure with these two RR interval, the rate will be a little faster. If we make it here, it will be a little slower. So I like to count all of them, and there are 11 ones, so rate is 66 beats per minute. And let's look at the numbers. And we can always say approximate number, but then life becomes approximate everywhere. I don't like that. If we measure here, the trick to measure is find a caliper or find where the QRS. So I can see here that the QRS is starting from here. And if I go backward, my PR is up to here. And that makes it 4 boxes and a little bit more than that. So it's 190 millisecond PR interval. And that's normal. And then QRS duration. From here, you can see that a little bit over 2 boxes. That makes it about 90 milliseconds. And then QT interval from the beginning of the QRS to the end of the T wave is 420 milliseconds. Please practice this. Approximation is never good. We never give money to the shopkeeper. Oh, by the way, you take 49 taka. We always count it to the penny. So likewise, in real practice, we should practice this until we sharpen our eyes enough. And then look at the QRS axis. Lead 1 is positive, so it's on the right side, and lead AVF is positive, so it's between 0 and 90 degrees. And if you want to be a little bit more accurate, if you look at lead 3 is here, and lead 3 is negative. So it is between 0 and 30 degrees. So if you want to be precise, you can go by that. So the axis is between 0 and 30 degrees. And then, of course, we looked at other things. We looked at the voltage is normal. If we should comment on something on this ECG. There is poor ROA progression from V1 to V5, V4. Why that is? Most probably it's a female patient. Sometimes the leads are not placed a little properly. And that is probably the most reason. And then we look at the ST segment is normal. T wave is upright. And so this is a normal ECG. So yes, always normal ECG at the first instinct, then we have to justify why it is normal. Thank you.
Thank you, sir.
Yeah.
There is an U wave.
Yeah.
Yes.
But this is normal UF.
Yeah,
Yes.
this is normal U wave.
Yes.
This is of course normal U
Exactly.
wave. But the thing is that if we are doing this exam, then probably I would put most scores on the U wave, because it is important to notice that this is an upright U wave without probably any consequence in this patient. But this
Yes.
is important to recognize.
Fantastic. Thank you. So one of the things that we're going to do today is, because when you look at a competition, if I give normal ECG, then we have to look at, as Hafiz mentioned, we have to look at all the points. That did somebody pay attention to all the features of this ECG, and that will be important to differentiate between our eyes.
And Mufik bhai, I know you don't like the cricket as much as I do. You don't give a dot ball in the first ball of the over, first innings. if I were setting the questions, I would have said this in the middle of the exam.
Can I add something?
Yeah.
Yes, sir.
Okay, fine.
Varun, sir, please.
Yes. Please do.
Yes, sir. Oh, yeah. In fact, somebody was telling regarding this UA, these UAVs are absolutely normal. But only thing is that the small UA may be very important if it is inverted in V1, V2, and V3. Because inverted POFs in the leads V1 to V4 indicates LED obstruction. And another one is normal. But only thing is that the small UA, this is normal. This is absolutely normal. It is inverted in V1, V2, and V3. Because inverted POF in the lead V1 to V4 indicates LED obstruction. And another one is normal. But only thing is that the small UA, this is normal.
There is a lot of
One
echo.
important thing is that if this age of the patient is 27 and she is a female, so we know that this ECG is normal. But if this ECG is normal, because this patient has got definite poor ROA progression from V1 to V4, and there's the students must know that what is the transition zone. How you define this poor ROA progression. The transition zone is V3. If the ROA amplitude in V3 is less than 3 millimeter, it indicates the poor ROA progression. And another thing is that if this is apparently looks that there is positional change, but we know that because this is a 27 years old lady, I think looks like that. So this one is very important. This looks like, say, somewhat like clockwise rotation of the heart. If you see that there is very poor ROA progression, even the transition zone has been moved to the V6. Only in the V6, the ROA is bigger than the SOA. So it looks like somewhat the clockwise rotation of the heart. But in this 27 years old lady, this is normal. But we have to think whether the patient has got an old anterior infarction. If this patient's age is more than 60 or there are multiple coronary risk factors, we must think about it.
Can I add something?
Yes, sir. Yeah. Please.
Look at also the T wave in lead 3. This is inverted. It doesn't mean anything. Unless you have a T wave inversion as well in other inferior leads, either lead 2 or FEF or all of or both of them, along with the inverted T in 3, it won't matter. Single Q or single T inversion in lead 3 doesn't matter.
It doesn't matter.
Thank you, sir.
Can I make a just quick comment?
Yes.
When I look at an ECG, I usually do not look at the age of the patient because I have seen patients with acute MI at the age of 27. So, but when we see the poor RF progression, we should go through the differential diagnosis that Boren mentioned, that it can be counterclockwise rotation, it can be ischemia, it can be just lead position, especially in females. The lead position is very, very common.
Lead downward.
More so in Bangalore, either down or up, one or the other. Either it will be placed too low or too high, and this happens. Thank you.
Ravik bhai, as always, I say exactly opposite what you say. So when I look at the EKG, I read almost, when I'm in the hospital, I read about 130 EKGs a day. But what I do, I go to the conference, I read the EKGs first. I look at everything in the EKG. The patient's age, where is the patient? Is it trauma or neurosurgical ICU or MICU or CVCU? And then I look at everything of the patient. And when I give it, and including one thing, I like the doctor from Nepal, and I tell my fellows, excellent job that you looked at the calibration and the speed. And you introduce that way. Excellent point. And the second thing is that intervals, the computer is very good in intervals and axis, but not the morphology. So there is no reason not to look at those. You know, heart rate, you don't need to calculate. Look at this. Pay attention to the intervals and everything. So I am telling you exactly the opposite Dr. Ravik bhai is saying. Ravik bhai is purist. I'm contaminated.
No, I mean, no question, I appreciate. But what happens is that there was a patient in 1991, I was working in the emergency room. Patient was tossing around, patient 22-year-old, everybody thought there's a drug addict, and nobody even looked at the EKG. When I looked at the ECG had ST depression in V1 to V6, lead 2-3 AVF. We took the patient to the cath lab, had tight stenosis of LAD, left main, and RCA. So, I mean, absolutely right. I mean, look at the finding and then look at the clinical scenario of the patient. No question about it. Thank you. Okay, next one.
Yes, sir. So this is ECG number 2. May I request Dr. Hirual Amin? Hirual Amin, are you with us? Dr. Hiru?
Sir, Assalamu alaikum, sir.
Okay. Can you read this ECG for us?
Sir, this is a 12-lead ECG with normal calibration, with normal spread, and there is rate is about 70, and there is left axis deviation, and PR interval is normal, and QRS is wide more than 120 milliseconds, and there is notching in one and LVL, and there is also V1 widening of the QRS, and V6 upright QRS is widening. So ECG diagnosis, this is an LBB type ECG.
Thank you. Thank you, Dr. Hiru. May I request Professor Abdul Wadud Chowdhury sir to make comments on this?
Hiru has a beautifully initial presentation is very good. Now look at the our system. Whenever you are describing, if you can follow the system again, the rate is 72 beats per minute, the rhythm is sinus, regular, and PR interval is normal. We can char code that approximately the P waves apparently normal. The QS complex show LPPP morphology. The ST segment is no, as apparently is normal. The T wave is quite all right. But with LPPP morphology, the T wave should have been inverted in 1 FEL56, at least B6. It's not there. And in a 67-year-old female person, that should be considered significant. There is likely to be primary T-wave changes. And I would be asking whether the patient have any chest pain episode or anything like that.
Thank you, sir. Rafiq sir, do you want to make any more comment?
No, I would like to ask Hafiz. Hafiz, are you with me?
Yeah, Rohit bhai.
I mean, there is a lot of, every time we see left bundle, right bundle, we worry about is something terrible going to happen to this patient?
Right.
Any comment on this bundle branch and structural abnormality or ischemia issue? Any concern regarding mortality of this patient?
Since you asked me that when I teach the EKGs, philosophically, we teach the EKGs in the classroom. But EKGs are like something that we should recognize, because whether you are in front of a tiger or an elephant, or you are in front of a dummy, you need to be very careful, because if you are in front of a tiger, you have split seconds to decide. So it's very important. And that's why you need to see the tiger and the fish. If it is a fish, call the fish a fish. If it is tiger, call a tiger a tiger. And that's why it is important. And I like this title, that EKG and beyond. We are clinicians. We encounter EKGs and we face clinical situation. So if you are seeing an animal in Sundarban and it is a tiger, you have a split second to recognize. Then you don't go through the whole algorithm, but you need to be familiar with this. That all processes, what Professor Wadud Chowdhury said, all processes will be processed in very split seconds. So therefore, EKGs, many of these should be in the brainstem, not in cerebral cortex. So that's why that's how I train the fellows. Here, Rafiq Bhai said, okay, this is a left bundle. He is absolutely right. But is there anything that says that it is a tiger in front? So is there anything ominous? For that, first thing you need to realize that I'm telling in front of in the practical part. Are you seeing this EKG in a zoo or in Sundarban? If it is in a zoo, that means you're in an office setting, patient is asymptomatic, don't worry. Don't call the ambulance for left bundle and acute coronary syndrome. But if you are in the jungle, and then you need to be careful. Does the animal move? Does it look like tiger? So what we need to know is that whether there is any Garbosa criteria to indicate that acute coronary syndrome going on. And for that, you have the patient in front of you. Now, if it is in the office setting, another question comes in. Left bundle, if you look at the Framingham data, left bundle has poor prognosis compared to right bundle, which is probably has no prognostic implications down the line. So that's what I have to say.
Thank you, Hafid. I think the very valid point. If it is right bundle, we can mostly ignore it. But if it is left bundle, we need to we should not panic, call ambulance, but we need to pay attention to it a little bit. And then Wadud pointed out something that lead 1 in AVL should have been inverted, and that's positive. That's unusual. That doesn't mean, again, I'm going to call ambulance and the patient to the hospital, but I need to take a real thorough history and really investigate this. Why is there discrepancy in this? So these are the clinical things that we are trying to teach, not only reading the ECG plus beyond, as Hafiz mentioned, that beyond what it is. Thank you.
Sir.
Next one.
Next one. This is ECG number 3. Dr. Kamal Hussain Obi is with us. Dr. Kamal, can you unmute yourself? Dr. Kamal.
Sir, Assalamu alaikum, sir.
Okay, can you read this ECG for us? What was your
interpretation? This is the 12-lead ECG showing there is a normal standardization, and paper is not showing here, but there is a heart rate is 1, 2, 3, 4, 5, 6. Heart rate is 50 beats per minute. Rhythm is sinus rhythm, and the
what is the rate? Heart rate?
Left the heart rate is 1, 2, 3, 4, 5, 6. 50 beats per minute.
No, 6 times 6. 36.
It's written in the ECG. You can,
46
you can read it is written heart rate 46. That is the way.
Yeah, fine. Okay, go ahead.
And there is a normal P wave. P wave. Here 1, 2, 3, 1, 2, 3, 4. PR interval is 200 millisecond. QRS complex is 90 millisecond, and QRST QT interval is 1 to 10, 11, 4, 12, 480 millisecond, and 480 millisecond, and there is a T inversion in the lead B1, B2, B3, B4, B4. So my ECG diagnosis is most probably in N2 ischemia, sir, and sinus rhythm.
Sinus what? Rhythm, but rate is?
Rate is 46.
So?
Sinus bradycardia, sir.
Sir, can I describe something about this?
Sir, I will come to you later. May I request Dr. Abdul Jamil, sir, to make some comment?
He mentioned the rates and all the morphology of QRS and okay, but he missed there are some humps at the end of each T wave in all the leads. Probably if I consider this as a P wave, then every alternate P wave was not conducted. Though PR interval is fixed in before the QRS complexes, and the non-conducted and conducted PP intervals are almost regular. So most likely it is 2:1 atrioventricular block.
Wadud bhai.
I always say to my students, please pay attention to lead 1. If you give attention to it, if you give jot to it, it will give return you make something. Look at lead 1, P, Q, S, T. There's something then. And what is that? It looks like the next P. Is it 2:1? Is it P wave that's not conducted? Look down the line. The same wave is present across the board. And it looks like the previous P wave or the subsequent P wave. So that is 2:1. Again, he missed another point. There's right bundle branch morphology. Is there anything else? Going down, you find
left
out
axis.
Its QRS complex is upright in lead 1, it's down in lead 2 and 3. So there's left axis deviation. That means there's also left ventricular hemiblock. That means the patient have at the level of 2:1 AV block along with RPPP and left ventricular hemiblock as well. Is there anything else? There is also T wave inversion. Where? It is in V1, V2. But with RPPP, we are expecting that. That's not part of anything ischemic or something else. It's part of the right bundle branch morphology, secondary changes. So what comes down, we have bradycardia due to 2:1 AV block with the QRS complex also showing bifascicular block pattern. So there is bifascicular block with 2:1 AV block with bradycardia.
Thank you, sir.
One of the things. Now the question, my question is being devil's. If I say, look, this is sinus bradycardia with the E wave, what is the problem with that?
The thing is, sir, look at the, whenever you are in doubt whether it is a P wave or not, go to V1. That will bail you out. Look at V1, there is a biphasic P wave. look at the so-called P wave that's not conducted. It's also biphasic. So that is actually P wave. It's not an U wave. That helps you out to differentiate it from U wave.
Can I make a comment, sir?
Yeah, thank you, Wadud. So we're trying to make a point that, look, when there is bradycardia, I always look for a second P wave. It can be true sinus bradycardia. Second, I saw something which Dr. Wadud mentioned, and it is a little too sharp for a U wave. But then again, also look at lead V1, it looks exactly like the other P waves, so that's 2 to 1. And then of course, other thing is that it has right bundle left anterior fascicular block, and that makes it more likely. This becomes very difficult when you have left bundle. If the rate was a little faster, then P wave then will fit inside the T wave. That will make it a little bit more difficult. But unless we keep a high degree of suspicion, we will have problem. The problem is this patient's symptom was exertional shortness of breath. Not a big deal, but we had a situation where this ECG was missed, not this patient. Patient had intermittent 2 to 1 heart block, and patient then went to the operating room for gallbladder surgery and arrested in the operating room. So that can have serious clinical consequence. So please keep that in mind. Thank you.
Thank you.
Rovik bhai.
Yeah.
U wave would not appear exactly the time of P wave.
Yes.
The timing is impeccable. It maps out, and then you know a person by the company it keeps. This 2 to 1 heart block, the company is bad, right bundle and left axis. So this company is bad, so this is a bad EKG.
I mean, so the whole point is that, I mean, Hafiz, me, Wadud, Professor Baran Chakri, everybody, we have so many years of experience. And how did we do it? We can think in different direction at the same time. And we are trying to do that as you are younger doctors who are here. Don't be frustrated that you made a mistake. Don't be frustrated that you couldn't recognize it, but it will come as you keep practicing it over the years. This will come. And all those things will fit in place. Thank you, Hafiz.
Sir, we can move to next one.
I like to know previous one, sir. Previous one. Is there any conducted P wave? Some PR interval is prolonged here, sir. In that case, RBB and left axis deviation, that means left anterior hemi block and first degree heart block, trifascicular block. And as we have seen in lead 5, there is a 2:1 heart block. As a whole, our final comments, which one is more appropriate, preferable?
It's basically sinus rhythm with 2 to 1 Mobius 2, most probably Mobius 2 second degree heart block with right bundle block, left anterior fascicular block.
Okay,
thank you, sir.
Thank you, sir.
Next one, sir, please. Dr. Manoj Koryala. Dr. Manoj Koryala, are with us? Dr. Manoj?
Anyone from Nepal?
Hello?
Dr.
Hello?
Manoj, please unmute.
Hello?
Yes, Manoj Koirala.
Hello, sir.
Yes,
Am I audible? Am I audible,
yes,
sir?
you are audible. You are audible, please.
Yes, sir. This is dual lead ECG. Sir, this is dual lead ECG with normal standardization with heart rate of 1, 2, 3, 4, 4.5, with heart rate of around 70 beats per minute. Rhythm it is the best rhythm. We can see the small spikes just before the QRS complex. So it is the best rhythm. And the morphology, we can see the PR interval is within normal limit. We can see the P waves in just before the each QRS complex. The QRS is slightly widened because of pest rhythm, and the morphology of the QRS is LBB type. So probably, sir, this is the pace rhythm. Right ventricle is paced, sir. This is the pace rhythm due to the patient is having the pacemaker in right ventricle, sir.
Okay. Is it a dual chamber or single chamber?
Right ventricle, yes, single chamber pacemaker is right ventricular is paced.
Okay. May I request Rafiq sir to make comments, sir?
You did excellent interpretation of this ECG, and the fact that if you look at this ECG, in most of the leads, you cannot see a pacing spike except in V5, V4, V5, V6. That's important. A lot of these new ECG machines have filtering system that they filter out these pacing spikes. So I'm glad that you noticed that. And the fact that there is P wave before each QRS complex, that means there is AV synchrony. And in the pacemaker in present, it must be a dual chamber pacemaker. So please, if you tell me this is a ventricular pacemaker, I will take it because you did a wonderful job. But because there is P to QRS relationship, it must be a dual chamber pacemaker. And my report will be atrial sensed ventricular paced rhythm. And once we have ventricular paced rhythm, we don't have any further comment about the QRS complex or or ischemia or anything. But you did wonderfully that it's a right ventricular pacing because it's a left bundle morphology type. Thank you.
Sir, can I add something?
Yes, please.
Whenever you have left bundle morphology in 1 and AVL, but in the chest lead, you have negative QRS complex across the board from V1 to V6. Always look out for spike in front of the QRS. It's a very characteristic of RV pacing. And then look out for synchrony, AV synchrony. Is there any P wave, which is most obviously usually found in V1 mostly? And if there is a P wave in there, that puts it in a dual chamber.
So can I add one point?
Sure.
Yes, sir. Javan, sir.
So in AVR, it is a tall R wave. It indicates the pacing from the apex of the right ventricle.
Yes. I mean, that explains why V6 is negative. Because most of the cases in dual chamber pacing, you find the V6 should be also left bundle type. But here, as Wadud mentioned, it's all negative. That means the lead probably is very apical location. That's why it gave this positive in lead AVR and negative in V6. Thank you.
Sir, what is the point in favor of the dual chamber, sir?
Oh, because there is P wave before each QRS complex, number one, and there is constant relationship. The PR interval is constant. That means the atrium is being tracked by the ventricle. So that's why it is an atrial sensed ventricular paced rhythm.
Right, sir.
Thank you.
Thank you, sir.
So the next one, Dr. Wasik Faisal Rajiv. Dr. Wasik Faisal Rajiv.
Assalamu alaikum, sir. Can you hear me?
Yes, we can.
Sir, I'm sorry for my voice because I'm COVID positive since 2 days. So this is a 12 bridge surface ECG with a normal calibration and speed. Heart rate is about 82 beats per minute. QRS axis is normal. It is there is a small pacing spike before every POF, and QRS duration is about 94 milliseconds, except the 8 and 12 complex in the rhythm strip. The PR interval is about PR interval is about 218 milliseconds, and QT interval is around 400 milliseconds. So my ECG diagnosis is it is a pacing ECG, probably with dual chamber pacemaker, and there is atrial pacing and ventricular sensing, except the 8 and 12 complex, which is there is atrial pacing failure followed by ventricular pacing. Thank you, sir.
Thank you, Rajiv. It was very good explanation. We have got Dr. Muqaddas Hussain Sadi. Dr. Sadi, can you make some comments on it? Probably no. Wadud sir, can you make some comment?
Yeah. He has made some comment if there is pacing failure or not. I would go for whether that occurred, the pacing for the next beat occurred at the proper time or not. If that is so, then the pacing has, atrial pacing has occurred, but there is a PVC. This has fused together before the conduction of the atrial rhythm into the ventricle.
Thank you, sir. Rafiq sir, your comment, please.
Thank you. Excellent. I mean, I'm impressed with this interpretation because you see, this is the computer-generated report that I left it on purpose. And this is one of the things that is done in American Board of Internal Medicine cardiology exam, that we give some machine interpretation to correct it. And this, he did not get biased by it. That's excellent. He noticed the pacing spike. That's wonderful. And as Wadud mentioned, this white QRS is a ventricular premature beat. And this one, there is a pacing spike. But this pacing spike, if I put a caliper, it's exactly on time for the atrial pacing. It looks like that it is pacing the ventricle, but actually it is just pacing spike in the atria. The other small comment that I would probably make is low voltage in the chest lead. If you look at the chest leads, it's less than 10 millimeter in all the leads. So that comment should be made with non-specific T-wave. As I said that we will report it because this is not a paced ventricular rhythm. Otherwise, I think excellent interpretation. And this is what I have done. I have expanded magnified the ventricular. Other physicians who did not notice this, that if you look at when I magnify, I can see the pacing spike here. You see this pacing spike, but excellent. Thank you.
Thank you, sir. Next one, sir, please. Dr. Buddhadev Ganguly. Dr. Buddhadev.
Hey, yes, sir.
Yes, sir.
There is normal sinus rhythm POA present while the QRS complex. There is ST elevation is lead 2, lead 3, and lead ABF, and there is reciprocal ST depression 1 and ABL. Also, there is ST depression is V1 and V2. There is taller and upward T wave in V2, and there is slight ST elevation is V4. So my final diagnosis is STMI inferior with possible posterior extension with RV infraction. So we do posterior side ECG and right side ECG for final diagnosis.
Thank you, Gurudev. May I request Professor Maski, Professor Arun Maski, your comments.
Yeah, thank you. So what he has rightly said was we can see P waves in V6. So this is a ST elevation in inferior leads, more on lead 3 than lead 2. There's a reciprocal depression in 1 AVL, and V2, V1, V2 has ST depression. So this looks like a inferior and possibly posterior. We'll have to do 7, 8, 9. And since there's a 1 and AVL ST depression, so this is a case of 3 is more than 2. It's a case of possibly right inferior MI, RC occlusion. So we'll have to do right-sided chest leads and 7, 8, 9 also. And we'll have to assess hemodynamically status of this patient. So management-wide, we need to give fluid in this patient and rule out RV infarctions.
Thank you. Professor Hafiz sir.
Bye.
Professor
Can I make a comment?
Yes. Sure,
Yeah.
sir.
In fact, this ECG has got definitely has got signs of inferior MI. But only thing is that there's just now Arun told this ST elevation is more in late 3 than late 2, it indicates that the inferior MI possibly due to RC occlusion. But if it reversed, if ST elevation is more in lead 2 than lead 3, it indicates that LCX obstruction. Case of this inferior MI is due to RC occlusion. But from this 12-plate ECG, is very difficult to comment on this RV infarct until unless we do the right-sided leads, because only one sign that indicates this patient has got inferior MI along with the RV infarction. Only look at the V1. If V1 is down, then possibly there is no right ventricular infarction. It's a standard teaching. But if V1 is even isoelectric, even it indicates that the patient may have that RV infarct also. But until and unless we do the right-sided leads, the RV infarction comment is very difficult. But one thing is important, the ST depression in V1 and V2. Look at the ST depression is more marked in V2 than V1. It indicates that possibly the patient has got concurrent posterior infarction also. But we don't have the lead V6, B7, 8, 9. Until unless we do that, that one is very difficult. But this ECG looks like this patient has got inferior myocardial infarction, possibly with possibly with posterior infarction, and possibly due to RC occlusion.
Can I add something?
Thank you.
Yes, sir, please.
We tell our students in the setting of acute ST elevated inferior MI, if ST segment in V1 is isoelectric or elevated, and in V2 it is depressed, where it is RV infarction, you have to confirm it by right side. But if there is ST depression in V1, V2 both, it's very unlikely the patient have RV infarction. And you should do the posterior lead and confirm that whether the patient have posterior infarction extension.
Thank you, sir.
One factor, if you have a ST depression in one and AVL, it's unlikely to have a circumflex. It is more pointing towards the right.
You are right, sir.
But if the proximal circumflex is occluded, it may give rise to ST depression in AVL. It's very proximal circumflex.
You know, in that case, the OM branch, which supplies the lateral wall, high lateral wall, that's effect.
Yeah, sir, V5 and V6 should have the ST elevation. Yes. At that time, definitely.
The ST elevation.
Thank you, sir. Thank you, sir. Okay. Perfect, sir. We can move to the next one.
Okay. So we talked about the corner. We talked about the coronaries. This is the left system of the patient.
So Rovik bhai, I tell you because I was asked to have a comment.
Yes.
So this is apparently, you know, we look at the ST changes and the rhythm. So rhythm is important. So you say acute ST elevation MI. So I tell the fellows few things, that when you look at the EKG, it is, and I like this forum because it is not about EKG, it is EKG and beyond. And what is in the beyond? Beyond means, is it really ST elevation MI? This is very important. And if it is, are we dealing with just inferior ST elevation MI, or there is a posterior extension, there is RV infarct, or there is some mechanical complication? So you need to look at the history, look at the physical exam. If the patient is not hypotensive, there is no heart murmur, there is no AI murmur, this is probably acute uncomplicated inferior, and describe to me like that way. Don't waste your time doing 12-lead EKG and compromise the dot to balloon time. But if you can do it, fine. But I'm not worried about that. This EKG does not indicate RV infarct by the look of it. However, we need to make sure that there is differential. We had patients with inferior systolic murmur, VSD. We had patients with inferior with AI murmur, it's echoic aortic dissection going into the right coronary. So this is very important, that just looking at this, you think that, oh, this is, let's move. Evaluate as much as you can, because it is important to note that acute posterior without inferior is very rare, but that can happen. And we need to always look at the proportionate ST reciprocal or disproportionate ST reciprocal. If there is a disproportionate reciprocal, then you know there is more than just what it is. So it is very important that inferior looks like easier MI, but you may have something behind it that may come back and haunt you. So this is all brainstem reflexes. Inferior, look at the EKG, look at the patient history, physical, then there is any complication or impending complication. All these in totality have to be evaluated. And I don't really worry about this Marriott description about, inferior ST more higher in 2 and SARC or RCA. We get burned out with this. Only time I look at this if there is a really crunch time for dot to balloon, that we are in the last. So should I go with the guide prepared and then open it up so I meet the dot to balloon?
Okay, Hafiz, I don't do angiogram, so make it simple for me. 2-3 AVF ST elevation and the mirror image ST depression in V1 and V2, right?
Yes.
That's a simple inferior microinfarction. Now in this patient, there is 1 and AVL ST depression. So if I am looking at this patient, how do I explain? Give me 2 simple explanations for ST depression in 1 and AVL.
So it could be in lateral ischemia going on, that is large RCA, or it may be a dominant SERC with OM. We don't know, but that is less of an importance.
Yeah, no. Phil, I'm not trying to just for simple mind. So we have to consider those 2 things, right? A big RCA, or maybe circumflex supplying the info, one or the other. So this is the angiogram. Comment on that, please. I am not the guy to comment on this angio. This is the LAD.
Yeah. We are plumbers, Rafiq Bhai. We don't explain EKG. We just
no. This picture. Yeah. Now look at the picture.
For the brain power, we go to EP.
Okay. Tell me about this one. What do you think, Hafiz?
So this looks like an RAO caudal view. You can see the diaphragm, the spine on the right, and then you look at the left main at the beginning, and then you look at the front LAD, and then this circumflex comes in, and then we see high-grade stenosis in the circumflex giving rise to an OM branch. We are not able to see the prox circumflex very well. We may need a LAO caudal view, but there is also what looks like a high-grade stenosis in probably the prox LAD because it is coming before the first septal perforator.
Okay. So this is the
vessel. The LAD lesion is ulcerated, looks like ulcerated plug.
Yeah. So this is the left side and this is the right side. And so basically right was totally occluded and it was stented out. But it was 3 vessel disease, right? So that stenosis can explain the lateral ST depression, right, in the circumflex?
Yeah.
Okay.
Can I add something, sir?
Sure.
Look at the heart. And if you look at this, heart is like this. The inferior wall is like this, oblique. And actually, one APL is opposite to the inferior wall because the heart lies obliquely. And the anterior depression actually not the mirror change. It's actually the posterior wall if it is involved somehow. If it is ischemic, then you get the anterior changes. Otherwise, not.
Okay. Thank you. So this one.
Dr. Sajidur Rahman. Dr. Mohammad Sajidur Rahman, your interpretation of this CG.
Assalamu alaikum, sir.
Dr. Sajid, go on.
So while he's thinking, let me tell you some comments from Dr. Shahabuddin Rahmatullah. Rahib, you know him, the godfather of myocardial viability. So Kim Eagle and Shahabuddin Rahmatullah, they were teaching EKGs in a board review course long time ago, and I still remember. Shahabuddin Rahmatullah said, okay, I'm going to show you the EKG. No comments, no fight. This is it. I don't care what you think. This is what the board wants. So because EKG is very important because all cardiologists, they become very emotional about EKG interpretation. So I actually take it very, very lightly. I said, okay, read the obvious and manage the patient.
Exactly. Dr. Sajidur? Sir. Can you make comments? Yes.
Yes, sir. This is a quad lead ECG showing heart rate about 74 beats per minute. Rhythm is sinus. QRS duration normal. PR interval normal. And ST elevation is seen in 1 AVL and V1 to V3. So my ECG interpretation is this is acute ST elevated MI anteroceptal.
Okay. Dr. Khondokar Asadujaman. Khondokar Asad, do you want to make?
I can hear you very clearly. Thank you very much.
Okay.
You already mentioned a lot of points here, but another important issue is you can see here the ST elevations in 1 AVL also. This should be included in this diagnosis as well as the anterolateral MI, maybe an important issue. And second issue is there is also the ST depressions in lead 2 as well as AVF. So it should make some differential diagnosis like whether it may be a case of even pericarditis, acute pericarditis, maybe the differential in these cases, I think.
Professor Hafiz, sir.
Sorry. Yes, so when you talk about mitral stenosis, the cause is rheumatic fever 3 times. There are some instances in medicine where differential is good to entertain, but that should be entertained last. So I would not entertain the pericarditis here because this is a very important issue not to entertain pericarditis in this. But there is lead 1 in AVL, so this is whether this is just anteroceptal or it is just anterolateral, that is the issue. And I would call it not only injury pattern, I would call it also recent MI because you can see the Q wave appearing in B1, B2. So this is, and then rhythm-wise it is sinus. And this looks like an acute extensive anterolateral MI. And another important thing that which is very interesting to me, actually more interesting than the ST elevation, that look at the V4. This is almost angle-wise, this is like a D Winters. If you don't look at nothing, but there is V4, V5, V6, all similar, like in V4, it is the suggestive of LAD disease, probably mid to distal. But here, it looks like prox LAD more likely, but it's very extensive. And I don't know, Rafiq Bhai, but this is our observation, and this is reported also, that the more the ST elevation and looking like, almost like shark fin, these patients are very vulnerable for VFib arrest. So if you don't act quickly and revascularize them or do something, this may go into disaster. And another important thing is the mechanical problem. So this may go into soon the electrical instability and also mechanical instability. So this is very important to recognize that this is not just a 50-year-old with uncomplicated inferior. This is a massive time bomb that we are setting.
Rafiq Bhai, can I add?
No.
Bhai, can I add?
Yes, sure, please do. Then I'll disagree with Hafiz.
Yeah, this ECG definitely is a classical anterior MI, but probably according to the book definition, it is not anteroceptal MI because ST is elevated in lead 1 and AVL also. But the ST is not elevated in V5, V6. One thing is that if you look at this ECG is very recent. You look at the V4, this V4 does not have any ST elevation. And this is a tall peak T waves. It is very angry looking T waves. So tall peak T, that means hyperacute T is remaining. So it is very recent. And another thing is that this ECG, it looks like this is a V1 is a very decisive lead in the anterior MI interpretation. Even V1 in the classical teaching, if the ST elevation is more than 2.5 millimeter in V1, it indicates proximal LED occlusion, possibly is before the septal 1 branch. So if you look at the V1, the ST elevation is more than 2.5 millimeter. So it indicates that the patient has got anterior MI and possibly it is due to occlusion of the proximal LED occlusion.
Good, thank you. So I have to disagree with Hafiz, always. So, sure, if I look at lead 1 and V2, I have the right to think of pericarditis, but then he gave my answer away because the V4, that T wave looks terrible. That doesn't fit in. So sure, I mean, we can always keep those in mind, and we have to keep those in mind, because then when we have those borderline cases, we may get into trouble. But the V4, everybody is pointing out that V4 T wave is really ugly looking, and that's
to add more. If you look at
Roy, 1 second. This one, if you look at the AVR, it does not tell you the diagnosis of pericarditis. There is no ST depression in AVR. So it goes against the diagnosis of pericarditis.
Actually,
another thing is that one important thing is that when ST elevation is lead oriented, specific lead oriented, that means only in the anterior leads. If there is any ST elevation in inferior leads, then we can guess that may have pericarditis. But this does not confirm anyway with pericarditis. If just looking at and otherwise the patient don't have any tachycardia also. In pericarditis, tachycardia is recently is always very remarkable. And AVR also is very remarkable. So this AVR does not say that this is a patient with pericarditis.
Yeah. So now you know why I said about Dr. Shahabuddin Rahmatullah's story.
Wadud, go ahead.
Rovik bhai, want to add the PR segment in AVR is typically elevated.
Yes.
And the PR is depressed in 2-3 AVF. Now, this argument about localization in the post-op period, we can see localized pericarditis, and that can be sometimes
pericarditis, correct.
So if the clinical setting is important, because just that you are seeing ST elevation in the localized area does not mean that this is MI, because it can be localized pericarditis. So we need to be careful about that. This VR, this is not only the T is ugly looking and hyperacute, but look at the angle. That angle is also very suggestive of LAD disease. We call that the De Winter sign. So all in totality, this is extensive anterior anterolateral MI.
Wadud wanted to say something.
But Hafiz, but by definition, classically it is not De Winters, because De Winters by definition, the origin of the upward stroke of the TOA must be below the baseline. But this one is not below the baseline, it is at the baseline. That's why I say it looks like De Winters, but it is classical definition, it is not De Winter. De Winter, the origin of the TOA must be below the baseline.
You notice that I said it's almost De Winters.
Almost.
Yeah, and you don't entertain De Winters when you have already classical.
Yes. Can I add, sir?
Only reserved for when there is no ST elevation. And that's why I clearly said that if it is only sign in there, you need to think about that. And hyperkalemia is always another differential. And I will show you the EKG about De Winters and hyperkalemia.
Sir,
but only thing is that only one sign indicates that it is not a hyperkalemia. In hyperkalemia, the T wave is always broad, is very narrow and very thick. But this one is a broad-based T wave. So broad-based T wave is very unlikely in hyperkalemia.
Yes.
Yeah. It is in the differential.
The important thing is in case of ST elevation MI, either inferior or the anterior, look at the reciprocal change. In case of anterior MI, you are going to have ST depression in inferior leads. If that is present, it's unlikely, very unlikely to be pericarditis. Again, ST elevation associated with Q waves, as we are seeing in V1, V2, also in 1 AVL. That's cross out actually pericarditis. The point is, what about the non-involvement of the 5 and 6 leads? Probably the posterolateral branch, WM branches are supplying that part of the heart. That's why it's spared.
Okay. So can we move on?
Sir, we can go for the next one, sir.
Okay, so look at the right coronary artery. As Wadud mentioned, it's a huge, big right coronary artery. And Wadud was absolutely right that the right coronary, I took 2 pictures. So You can see the lateral part is a pretty big right coronary artery, and this is the left. The LAD is occluded and then after stenting. So thank you.
So we have got Dr. Abdullah Mamun. Dr. Mamun.
Comments, sir?
Walaikum Assalam. Can you make some comments on this ECG?
This 12-lead ECG with normal calibration and normal speed shows rate is about more than 150 beats per minute. POF is absent, but rhythm is regular. QRS QRS duration is narrow, that is 40 millisecond, and there is no axis deviation, and POF is also there is also pseudo R in V1 and pseudo S in inferior leads, and STT change in 2-3 AVF also in 1, and also in V4, V5 and V6. So my ECG diagnosis is this is a narrow complex tachycardia, possibly supraventricular tachycardia.
Thank you, Mamun. Thank you very much. May I request Professor M. Atahar? Atahar, sir, please.
Thank you, Bruce, and thanks for excellent description and nice interpretation. Actually, has followed all the sequence we want to teach. That is, has described the rate. Rhythm, he has told that is the regular. I think rhythm should be supraventricular regular. He can tell supraventricular regular as it is narrow complex. So it is supposed to be supraventricular and regular. Then QRS complex, he has already mentioned the narrow. And finally, regular narrow complex tachycardia, supraventricular in origin, and he has got some points in favor of the AVNRT. That is his point that is the P priming in V1 and pseudo S in lead 2-3 AVF. So I think his diagnosis is correct. That is narrow complex supraventricular tachycardia and possibly AVNRT.
Thank you, sir. Rafik sir, do you want to add something?
Rafik bhai.
Yeah.
Rafik bhai.
Yeah.
Yeah. Can I make a comment?
Sure.
I agree with Dr. Atahar. This patient has got this pseudo R and pseudo S in lead 2, lead 3 and V1. But only thing is that in V4, V5, V6, in any form of supraventricular tachycardia, if there is ST depression in V4, V5, V6, it goes in favor of AVRT. So he has got some points in favor of AVRT also, because ST depression in V4, V5, V6 during a narrow complex tachycardia in AVNRT is very unusual.
I like to add another point with Professor Varan Chakraborty. If we look at the bottom strip, there is electrical alternation.
Yes, some alternation.
And that goes more favor with the concealed type of pathway. Ventricular pre-excitation is there.
Sure, thank you. So the ST depression sure can be AVRT, but it can also be rate dependent because it's a 75-year-old man with a heart.
Yes.
But this wave in V1 is important. Now, it can also be an RSR pattern in the vein. So what I do, unfortunately today I don't have the sinus rhythm ECG on this patient. I didn't have time to put it on. But if I can find the ECG after conversion, and then we don't see this one after conversion, then it is 100% AVNRT. If this R wave is gone in after conversion to sinus rhythm, then we definitely know this is a retrograde P wave, which is within 80 milliseconds of the QRS complex. Any retrograde P wave, 80 milliseconds before or after the QRS complex is more or less AVNRT. So that's about it. Thank you.
Rafik bhai, the issue is about when there is an EKG like this, it is an EP issue. So I usually don't step into the EP issues, but I look at the ST segment depression, right? So I look at the RP interval. So long RP, short RP, and go through the differential and look at the patient. ST changes will not determine whether this is AVRT or AVNRT. We can't interpret that way. The question is, in addition to the arrhythmias, whether there is any underlying coronary disease, that sometimes becomes an issue. And particularly in our emergency room, there is AVR, ST elevation, ST depression. They call for STEMI activation. So we need to be careful about over-interpretation in the presence of SVT. So that can be a compounding issue. I tell them, do not read this ST elevation in AVR and ST depression and overly call it. But the clinical context is important, and we'll have to think about that. If this is a 32-year-old female coming with this, don't call it STEMI. Then deal with the arrhythmias and then go for that.
Okay. Thank you. Thank you. Next one. Dr. Hiru Al-Amin. Dr. Hiru Al-Amin. Can you make some comments on it?
So, Assalamu alaikum, sir. This is an 12-lead ECG with normal calibration. Rate is about 190 beat per minute, and there is right axis deviation, and QRS is more than 120 milliseconds. That is wide QRS complex, and there is occasional capture bit is present, more marked in the lead 2, and there is ventricular concordance is also present. So and most likely this is a ECG wide complex QRS, wide complex tachycardia, most likely ventricular tachycardia.
Thank you, Dr. Hiru. Dr. Jamil Bhai, you want to make some comment on it? Dr. Abdul Jamil.
Yes. Most of the points he mentioned, all right. It's more in favor of ventricular tachycardia. And there is some fusion bit-like things are there. Maybe preceded by one P wave in the bottom strip. So 1, 2, 3, 4, 5. Near the middle of the strip, and 5 bits after that. It's most likely it's VT, what he's mentioned.
Can I add something?
Sure.
This one is definitely the broad complex tachycardia, and we know that 80% of the broad complex tachycardia is VT, and only other things are very less. But even then, in this ECG, there are some signs those goes in favor of SVT with aberrancy. That's why I want to tell something. What is that one? Because this ECG, what are the findings goes in favor of VT? VT is very broad complex. That means in a RBB morphology, if the QRS complex is more than 140 millisecond, that means it goes in favor of VT. Another thing is that concordance. If you look at the concordance, all the QRS complexes from V1 to V6, they're upright. So this one is concordant. But this concordance is positive concordance. Positive concordance is not sine qua non with VT. But if it is negative concordance, it goes very much in favor of VT. But if it is positive concordance, it may be due to aberrancy, and with accessory pathway, particularly in the left posterior pathway, it can be this type of case. Another thing is the diagnosis of VT. Usually VT. But this one is associated with right axis deviation. And another important thing which goes against VT, look at the morphology of the... Please mute. Look at the V1. If you look at the V1, if there's a classical teaching, if in the V1, if the QRS complex is then the left one, that means Rabidous sign right, it goes in favor of SVT with aberrancy. But if the left one is bigger than the right one, it goes in favor. That is Marriott sign also. So all the things goes in favor of SVT with aberrancy. So possibly it is VT, but it has got, this ECG has got several signs which goes in favor of SVT with aberrancy. And particularly the morphology of the QRS complex in right, in V1, where the right-sided or the right peak is bigger than that of the left peak. That means Revidia sign is positive. So it goes in favor of aberrancy. So it may be VT, but it has got some criteria in favor of SVT with aberrancy also.
What is your diagnosis?
It's my diagnosis. But only thing is that this QRS complex is very, very wide. That's why I'm in favor of VT. Otherwise, I could say that this one is SVT with aberrancy and left posterior accessory pathway. That's giving rise to that. But Hafiz does not believe in Marriott sign because this one is Marriott sign. If Marriott sign is correct, then it is SVT with aberrancy.
No, I do not.
But a patient with this like this, one teaching is treat it as VT.
Definitely, standard teaching is VT because 80% of
Treat
the
it as
complex
VT as because this might harm the patient. But if the patient is hemodynamically stable, then we can think of other things.
Definitely, because all broad complex tachycardia should be regarded as VT until proved otherwise.
Yes. So when I face this, I tell the resident and fellows, don't get intimidated. You can pray. Pray for, please pass out. I can shut you out. I'm going to tell you, I'm sure Rafiq Bhai is going to go through the organized way of describing what is in favor of VT, what is in favor of white complex.
Teaching class, that's why I'm telling that one. Otherwise, for me also it is VT.
So that's why I wanted to know. So in the board exam, it is one thing. In practice, it is another thing. You notice that Rafiq Bhai has taken everything out from this EKG. No clinical info. See that? Okay, Rafiq Bhai.
Rafiq sir, please, your comments.
So, no, I left the information, one information that to confuse everybody because this is a 34-year-old female.
I noticed that. Yeah.
I left it on purpose. Few things, a white QRS tachycardia. And so we look at, and it is right bundle morphology by V1, but not by V6. So if it happened that it is a right bundle aberration, lead 1, you can see R followed by S, but I should have seen also RS pattern in V6, which did not. So it is not one of those typical right bundle aberration. Concordance goes in favor of VT. Second will be QRS duration, as Boren mentioned, that right bundle more than 140 millisecond duration, left bundle more than 160 duration supports VT. This QRS was 220 milliseconds. So this was VT. This is a 34-year-old female who came to the hospital with fever. And then she did this in the hospital. And we shocked her out. And then what she had bidirectional ventricular tachycardia. And unfortunately, I did not put it today to make it simple. Basically, what we felt, we did EP study, it came her LV function was normal, coronaries were normal. And we could not use any VT, and we felt that it was catecholaminergic polymorphic ventricular CPVT, because we had actually classic bidirectional VT. There were QRS complex, one positive, one negative, one positive, one negative. So this was one of those cases. Thank you for all the input. But for the audience and the younger doctors, please take the message from all our confusing discussion that if you think white QRS complex, if you can't diagnose anything, call it VT. No question, because even if it is SVT in operation and you shock the patient, you have saved the life of the patient. But then we go to the algorithm, concordance, in this case, was the pointer towards the VT diagnosis. This is, I have nothing to do with it, Dr.
Topic, sir.
Yes.
In the previous EC, in each and every upstroke of the QRS complex, there is a notch. In some areas there is notch, some areas there is no notch. Does it indicate AV dissociation?
Oh, I normally try to find a P wave, and Hafiz said I always find something. I tried to find, but I could not. There is something, but the problem is that if you see here, there is something,
yes, yes.
There is something, but I have to find something very consistent and regular because there is so many notches. I just didn't want to make any comment, and I did not have any intracardiac on this. So when I try to identify a P wave, I have to confirm with another lead. At this rate, it becomes almost impossible to diagnose AV dissociation unless it is very, very clear P wave.
Thank you, sir.
Pardon, sir. I'd like to know a bidirectional VT. What are the features of bidirectional VT? Is there any here?
No, not in this ECG. This patient had another ECG subsequently on monitor that you will see the VT, one QRS is positive, other QRS is negative, and you see it in two conditions. One is CPVT, sometimes in digital is toxicity. You can see bidirectional VT. And probably the mechanism is same. It is due to calcium overload. So the mechanism of VT is similar, and it's a calcium current dependent VT. And next time I'll bring those ECGs for you.
Thank you, sir.
Thank you.
Next one, sir.
Yeah.
Next one. May I request Lieutenant Colonel Nizamul Hussain Chowdhury. Colonel Nizamul Hussain Chowdhury. Can you make some comments on this ECG?
Thank you, sir.
Yes.
It is 12 lead ECG with normal standardization and calibration, having rate is 74 beat per minute, sinus, rhythm sinus. P wave are tall, peaked. QRS morphology is RSR pattern, and there is a left axis deviation, and there is so considering all these, my clinical impression is a P pulmonally with RBB with right axis deviation, and there is features of RB hypertrophy also. So my clinical diagnosis, considering the clinical scenario, 40 years old female, it could be atrial septal defect, maybe most likely second term type ASD with RB pulmonary hypertension.
Thank you. Thank you very much. Dr. Govindopal, do you want to make some comment? Dr.
Yes,
Govindo.
Some of the points I like to add here. V1 is RSR pattern, RBB morphology, and V6 also, V5 and V6 also shows LBB morphology and strain pattern T inversion, and PR interval seems to be prolonged, and a little bit wide QRS complex. So in that case, here the RBB and LBB morphology, I like to mention here or comments here, the intraventricular conduction delay and right atrial enlargement up to this.
Okay, thank you. Dr. Naruma, you see your case. Make some
So
comments.
this one, can I make some comment?
Sir, let Dr. Naruma say a few words, then he will make the final comments. Dr. Naruma, please.
Thank you, sir. According to ECG, the finding that told is absolutely okay, that the P pulmonally, that means that PA pressure is high, and also it can also indicate that RA is enlarged, and it also if we correlate with the clinical findings that patient is 14 years female with shortness of breath and palpitation and wide split second heart sound. And there is two murmur in pulmonary area. There is systolic murmur and there is pan-systolic murmur in the left lower sternal area. I'm not going the details of the ECG finding, but it is giving a clue that pan-systolic murmur in the left lower sternal area. It indicates one thing that the tricuspid regurgitation is there, and which also we are finding in ECG that P is tall. And another important thing, PR is prolonged, and it indicates that in that Govinda told that interventricular conduction delay, that also happening in this case of patient. And there is a complete RBB. The QRS complex is more than 120 millisecond, and there is RVH is present, and LV forces is also short. LV forces is not overmarked. So from here we can tell it at ASD secondum with severe pulmonary hypertension, or we can also tell that it can be a case of Epstein anomaly, because in case of Epstein anomaly, the RA is enlarged and there may be in conduction delay, and there is RA, that atrialized RA, there is volume overload, so there is a PR prolonged conduction is malformed, it goes downwards, and so we are getting that PR prolonged, and that RBB is also we are getting because there is RB forces. And from this, we can tell that this patient has not RVOT obstruction. This is a severe RVH, and PA pressure is high. That's all.
Thank you. Professor Warren Sukhruvat, sir.
In fact, this ECG, in fact, everybody is in favor of second type of ASD, is it? So problem is that if this patient has got RBB, and P pulmonally, and PR interval is prolonged. In classical testing, if it is ASD, that ASD should be, at this patient has got a pansystolic murmur in the lower sternal edge. Why it is not primum type of ASD? Because primum type of ASD usually give rise to this RBB pattern along with the prolonged PR interval. Only thing is lacking, there is no profound left axis deviation. The trio of diagnosis, the primum type of ASD is RBB, then the prolonged PR interval along with left axis deviation. Except the left axis deviation, this ECG goes in favor of my diagnosis. The patient's age is only 14, has got a pansystolic murmur. So RBB with prolonged PR interval with P pulmonally goes in favor of diagnosis of primum ASD. But if you look at the RBB pattern, this RBB pattern is not normal. This is called atypical RBB pattern. And this atypical RBB pattern, and along with this tall V2, look at the V2. Usually the Epstein anomaly give rise to Himalayan P wave in the V2. What does it mean, Himalayan P? Himalayan P means if the P wave amplitude is more than 5 millimeter in V2, it goes in favor of Himalayan P wave. And this Himalayan P wave is usually present in Epstein's anomaly, tricuspid atresia. But it is 14 years, tricuspid atresia is very, very unlikely. So there's features of the Epstein's anomaly. Another thing goes in favor of Epstein's anomaly. If you look at the beginning of the QRS complex, there is some suggestion of the delta wave also. We know that this Epstein's anomaly, more than 42% are associated with ASD, and almost 25% has got the pre-excitation syndrome. So if we altogether take in consideration her pansystolic murmur, atypical RBB, prolonged PR interval, P pulmonally, everything goes in favor of Epstein's anomaly. So my diagnosis rises in two, as I did not see the patient clinically, either it is a septum primum type of ASD or it is an Epstein's anomaly.
Thank you, sir. Thank you very much. In fact, we are running out of time. We should stop here. We will move on to our next part of the.
Can I make just a quick comment?
Yes, sir. Please.
When I first saw this ECG, because I don't deal with congenital heart disease, one of the features of Epstein is 2 QRS complex. Look at VIS5. There are 2 QRS complexes. Look at V1. The sharp complex looked like QRS. Second one looks like T, but that's another QRS complex. So this is very pathognomonic idea. I found out that very much pathognomonic of Epstein anomaly, that if you look suddenly at the ECG looks like, and Govinda mentioned that it looks like left bundle, but actually what happened, the terminal part of the R wave is kind of desired S wave, is the QRS complex. That's actually the part of the QRS complex. So that's the typical part. A tall P wave can be first degree AV block and then looks like two QRS complexes. Thank you. This was a wonderful ECG. Dr. Naruma, thank you for sharing this.
Sir, I'd like to differ with Baranda.
Thank you, sir.
There is no clear excitation. The initial part is very short and there is no delta wave or something like that. Again, the PR interval is prolonged rather than short. So all this point goes against.
But if the patient has got Epstein's anomaly, the PR interval will not be short. Because that's the only thing I tell you theoretically.
Let me finish. Epstein anomaly has association with pre-excitation, but not all Epstein anomaly patient has pre-excitation. This is the ECG.
No, only 25%. Only 25%.
Yes. And this ECG does not have any.
Only 25%. But only problem is that in the Epstein's anomaly, the septal cusp of the triclassic valve is driven by distally. That's why it produces the anatomical problem in the central fibrous structure. That's why the PR interval cannot be short.
But there are a lot of patients with short PR interval with pre-excitation.
Yes, can.
In Epstein.
Sir, make a comment, sir. Right ventricular hypertrophy, in case of Epstein anomaly, usually rudimentary RV. So why voltage V2 taller in V2 and also V1? Why?
It is due to this bizarre pattern has been explained in Epstein's anomaly. This is not due to RV overload. Sorry, this RV hypertrophy. It is due to right bundle conduction defect in the right bundle. This is big bizarre QRS complex is due to this conduction delay. It is not the hypertrophy.
Thank you, sir.
I have a quick add-on that in Epstein's, this question is set up for suggestion that this is Epstein's until proven otherwise. But the S1 is split, not S2 in Epstein's. In Epstein's, because the first sound is because of the closure of the mitral valve and the tricuspid valve. And normally we don't see the first sound is split. In Epstein's, there is M1, T1 is split. First sound is split. That's a very characteristic of
Thank you, sir. Thank you very much, sir. Rafiq sir, thank you very much for showing us the ECG. Now, this is the next part of our session. We are going to declare the winners of the ECG quiz. And Dr. Tushar, can you declare the winners, results of the quiz? Dr. Tushar, please.
Tushar, are you with us?
You can show the result. If Tushar is
Firoz, you go ahead. Tushar, where are you?
Sir, I'm here, but the signal is not coming. Am I audible, sir?
You are audible. Now you can go forward.
Okay. Kamal bhai, can you please share the result? We have decided to announce 10 winners, but interestingly, we have 17 winners of this ECG quiz. A majority of there are 8 participants who answered correctly 9 questions, and 9 participants who answered 8 questions properly. So we decided not to. Yes, sir.
Kamul Shahab, apni
So we decided.
share karen.
Abdul, can you show us?
Please share this
winners
PowerPoint.
Sir, I'm sharing. Just give me 1 minute, sir. I'm sharing.
Okay.
20 seconds, not 1 minute.
Yeah. So, Wadud sir, So as there were 17 participants, so we decided not to cut anyone. So we included all the 17 participants who answered 8 and 9 questions properly.
So, sir, all the participants for Bangladesh or any Abdul?
No, there was another, one participant from Singapore also. And rest of the participants were from Bangladesh. And
how many participants?
I think
there was
none. I think they didn't have information.
Yes, we shared the information through Facebook page or Facebook page, but I think many participants were a bit deceived by the pattern we said to answer. So we are trying to encourage our participants to answer in the particular format. So I mean, many of the participants answered the questions, but the format was not, they were not giving the answer in formatted way. So only those who give it the answers in formatted way, we have taken those answers.
How many actually answered?
60. Actually, 56 participants answered according to the format.
Yes.
Yes, sir. This is the we are sharing the result now. So this was the 56. We have the participants who answered in a formatted way, and among the 17 was the winners. The first 8 answered 9 questions properly, and the last 9 answered 8 questions properly.
Can you read the names of the?
Yes, sir. Yes, sir. So the first one is Dr. Muhammad Wasik Faisal, then Dr. Mustaq Tazir, Dr. A.B.K. Bashiruddin, Dr. Nurul Islam, Dr. Buddhadev Ganguly, Dr. Mukul Chandra Paul, Dr. Atanu Dash, Dr. Muhammad Hiru Al Amin, Dr. Abu Naim Mahmud Hassan, Dr. Shomen Dash, Dr. Muhammad Shazidur Rahman, Dr. Abdullah Al Mamun, Dr. Muhammad Nizamul Hussain Chowdhury, Dr. Muhammad Hassanur Rahman, Dr. Kanta Dash, Dr. Tahmina Sultana, and last one, Dr. Qazi Fahim Mahmood. From the ECG study group, we congratulate all the winners of this ECG quiz. I request Wadud sir to say few things about the quiz and the winners and the overall participation. Wadud sir.
Good evening, everybody. Actually, our quiz attempted to enforce the idea of system and encourage to join with us in this contest in a formatted way. If you practice the same thing in your daily life, it will become part of your habit. And then the chances of missing out important piece of information will be much low. And the chance of giving the proper decision will be much higher. I really congratulate all the participants, not only the winners, and I heartily congratulate all the winners. We are really lucky to have you all with us. Our journey, our endeavor, all of our hard work actually paid off when you answered it so nicely. Thank you, everybody.
Thank you. Review, can you show the slide with the book Professor Boren Chakraborty sir which will be given to our winners. This is the book, Textbook of Basic and Advanced Electrocardiography, written by Professor Boren Chakraborty, and every winner will get one of these books. And congratulations to every winners and also for all the participants. Now, may I request Professor Boren Chakraborty sir to say a few words about today's session and the...
Steven, may I interfere? Yes. Very good book, and very readable book.
Thank you,
I
sir.
also already got it.
Okay.
With
Warren Chakraborty, sir, please.
Thank you,
Thank
sir.
you, everybody.
Can you stop sharing the book slides?
Yes.
Okay.
So thank you, everybody. So particularly Dr. Hafiz and Rafiq Bhai from abroad. So it was a very interesting session. And every time I contradicted, I know it this one, even then I contradicted, only to share that one, that these things can happen. So my book, the book written by me has been given to everybody, and this book I handed over to Dr. Arun Maski in India when it was first published last year. So far I can remember. Can you remember, Arun?
Yeah, thank you. That was very good. I read the book. But a lot of our participants are asking whether we can get that book. They are written in chat box.
It is also
so you'll have to provide.
It is published from Nepal also. It simultaneously published from India, London, United States, and so also from Nepal. 4 countries simultaneous. So this is a big book, particularly those who will do the post-graduation. This book has got 2 parts because 17 participants already own the book. I tell the gist what to do it. If you want to pass the FCPS, you will have to go through all the way. If you want to do the MD in cardiology, you'll have to go through all the way. But those who are MBBS students, only put, because every chapter has got 2 sessions. One is the details, another one is summary. If you want to recapitulate within 1 day, even you can recapitulate whole the ECG within 1 day also. If you are an MBBS student, read the summary part only. If you are a postgraduate student, you'll have to know everything. So you have to know the explanation of the waves. So if you want to read it, I think Dr. Wadud said I tried my level best to make it very up to date. And only one ECG regarding this book, I want to add one thing. What ECG books we get? We get the ECG books. The writers usually do. They summarize all the old books. But in this ECG, you will get because I take in consideration 2 journals. One is American Journal of Emergency Medicine. Another one is the Journal of Electrocardiography. And I summarized many new things. I did not tell it today because in ASD, there are so many new things, but I did not tell it. I summarized all the things in the text also. If you get time, that is good. Then if you read it and if you find it is worthy, then all the effort, I think it will be okay. So otherwise everything will go in vain. Thank you, Dr. Rafiq Bhai and Dr. Hafiz again for participating with us, Bangladeshi doctor.
Where we can get it in Bangladesh, in Dhaka?
So all the cardiologists have got it.
I didn't.
Or it is with the Beximco. Beximco is giving to all the cardiologists. So far I know they have all cardiologists. Jamil, it is assured that you will get it and you will get a big bubble also.
Thank you, sir. Thank you.
So Wadud Bhai,
yes.
Wadud Bhai,
yes.
You should do one thing. From ECG study group, you will have to give books to our residents who are regular in this class. That would be great.
Okay, you will get it.
We are planning for that.
Oh, this is the Beximco's problem. They will provide it.
We are
say something.
But Beximco is supporting us in this program very well.
So this book is a little bit expensive, around
they will also reach
3,000 taka.
Jamil
So
Bhai.
the Saira is here. Saira should provide everybody. Saira, is it?
Sir, of course.
Saira, can you hear it or not?
Yes, sir, yes.
She is in
Yes.
trouble. Thank you, Varun Chakraborty sir. Definitely will be benefited from your book, and congratulations for writing such a beautiful book. Now it's time for concluding the session. May I request Professor M. Atahar sir to conclude the session?
Sir, please, I want to have some comment from Rafiq sir regarding the quiz and everything.
Sir is not.
Rafiq sir.
Rafiq sir, he's back. Sir, please.
Thank you. I mean, this is a wonderful forum. I enjoy joining it. It's always my pleasure. And then I'm glad that participants are answering. I'm glad that the 56 people answered. And that's the question. I mean, we expect that you look at it systematically, continue doing it, and in the process, whatever we can do to enhance your knowledge, please let us know. It's always a pleasure. I learn a lot by learning, especially arguing with Hafiz. He makes me think all the time.
Hafiz sir is also with us. Hafiz sir, do you want to make any comment? Do you want to contradict with sir, Rafiq sir?
Are you going
Hafiz sir, please.
No, I don't have any comment. I really thank all those who participated. This program is successful because you participate.
Thank you, sir.
Thank you.
Atahar sir.
Atahar bhai, please.
So thank you, Firoz, and particularly to Robic sir, our target is okay. Particularly, possibly our target is successful. Particularly, your presence and Hafiz bhai's presence makes the session very interesting and everybody enjoys it. And our students are practicing in the way what you are teaching, that is systematically rate, rhythm like this. And this is the format actually we presented in the quiz, and they followed the format and they are practicing it. So our mission is successful. And most of the participants are juniors, sir. And I think most are in the, some of the students are in the actually medical students, even not yet passed the MBBS course. They have also participated in this session. So this was our target, not the seniors to actually faculties participate in the quiz. So in this contest, actually this was our mission and it is successful, I think. I like to congratulate all the participants who participate in the quiz contest and particularly those 17 winners. So congratulations to all, and particularly we are grateful to Ropik sir and Hafiz bhai, and today particularly Boren sir to make the program very, very successful and enjoyable. Thank you, Boren sir. We want to every day.
Please also.
Thank you. Thank you.
Atahar sir, any comment about the next session?
Yes, sir. There is a declaration in next Saturday, sir. Actually, there will be a talk from USA, Dr. Fisher, that is adult congenital heart disease. Sir, Ropik sir. Actually, the next Saturday he will be the speaker, sir. That is adult congenital heart disease. And I will also request Boren sir to be present on the session. I will send you the link and the invitation. Boren sir.
Can you make sure Dr. Naruma is there?
Yes, sir.
Yes, sir. She'll be, sir. And so also pediatric cardiology will be invited as a faculty in that day.
Sure.
Thank you, sir. Thank you. Now we can conclude the session. See you all on next Saturday. Thank you for joining us.
And we must congratulate, thank the Beximco team, particularly Saira Hossain, Ribu and the Kamal.
Thank you, sir. Thank you so much. Means a lot.
Try to reach Jamil bhai.
Of course. Of course. Yes, sir.
All cardiologists get the book.
Okay, sir. I will make sure that Jamil sir gets one. Of course. Inshallah.
Sir, we are giving the books as a prize, but we are also waiting for your books, sir.
So, Rivu, you should get books to our guys also.
To Nepal, sir.
Nepal. We'll have to send. I'll send the name. Thank you.
Okay.
Okay, you send to Rivu and Rivu will arrange.
Okay,
Thank you.
Thank you so much, sir.